Last but not least, Kobe Reisman from Amsterdam. The 3 Ps, no, it's not the old 3 Ps. I see Tom and Nicholas up there. It's a slightly different variation on that. So we've got porn, paint and piercing. Kobe.
Yeah. Thank you. Good morning, everyone. Thank you, David. Thank you, Duncan, for the invitation to be here. We are going to talk about another juicy subject. As you see, sexual medicine is huge, is large, is so interesting, and you are all welcome to join us in the next Congress of the ESSM. I will tell you at the end of my presentation. Anyway, let's start with porn. Do we like porn? What do you think? Yes, we do. Yeah, that's clear. Just to give you an estimation, this is how much the porn industry is involved. $13 billion, which is much more than what Google and Microsoft doing in their revenues. So we like porn very much. So we need to think about it in our variety, John, what you just told us. And how much we deal with it. 12% of the websites are with pornographic intent, which it means 24 million websites about pornography, and not only men are interested in porn. One of the 3 porn viewers are females, luckily. But there's also other aspects. Children nowadays are exposed to porn the first time at the age of 11, so that could have some consequences. And 20% of the men admit that they do it on work, and 30% of the female do it at work, so it's still a business, and the day that mostly porn is watched is on Sunday. Think about it. There are differences between males and females about porn. Women like more the interactive one, and they enjoy more the shared sexual activities. They want to talk, like the psychologists that you heard about. Women like to talk. But males are more visual orientated, and they are enjoying more the solitary activity. Is it bad or is it good? For everything in life there is bad and good, also for porn. It could have some risk, because it could give some difficulties with your morals and social and relationship problems. It could fill a gap in the real world. It could create a virtual reality with something like women are always getting an orgasm and they never complain. Where it could be, I don't know, but it's also could increase the health risk behavior. On the other side, it could increase our sexual repertoire. It will make acceptance of what we think something like bizarre, of spicy, of different. And it could also increase pleasure, certainly in a long-term relationship. But there is terms like porn addiction. What is porn addiction? Actually, we don't really know. There is no definition in the DSM-5, and we lack a defined criteria. So when we do some research about it, we don't know exactly what we're talking about. But you can think that it could be a problem if someone spends excessive amount of time viewing, or if it have significant impact on their daily life. Is it real addiction? There are some people who said it's totally different from alcohol, gambling, or drug addictions. There are certainly an out-of-control behavior, and it could be compulsive or impulsive, and sexual desire dysregulation. What we know is that the people with impulsive or compulsive disorder are more prone to get problems from these activities. And in the United States, the estimation is that there are about 200,000 Americans which are porn addictive. It means that they define it more than 11 hours a week spending on watching porn. And in this group of people, there is more loss of jobs, loss of support, and financial problems. Why it's not going further on? Okay. And if you think, am I porn addicted? You can check yourself, because you can ask yourself, Do you feel more consumed by the pornography? Are you risk your job? Are you risk your relationship? What your partner will feel about it if she know or if he knows about it? Which will be of the risk. And now we're looking at porn in inappropriate places, publics, library, coffee shops, work. Think about those issues. But at your office, as urologist or andrologist and sexual medicine persons, you can meet all kind of different persons who come with these questions. They could be an real addicted, according to the definitions, or they could be an recreational users with some worries, or there can be people with sexual problems who use porn and say that porn is the cause of their problems, or they use porn to solve these problems. And is it really a concern and it causes sexual problems? In general, we think quite often, if you watch a lot of porn, you will get some problems and you will have sexual difficulties. And recent study from Stuhlhofer and his colleagues showed that pornography does not seem to be a significant risk factor for younger men's sexual desire, erection, or orgasmic problems. So it's okay if you like it, if you do it in a proper time and without any risk for your job and for your normal life. But when they come to your office and real people with real problems, they usually minimize the consequences. Oh, it's not so like that, and it's not so often, and it's not so much, but mainly they lose their job, they are isolated from relationships, they lost the partners, or at least they got ultimatum from the partners. And the only way to deal with these people is when they have real desire to stop these activities. Otherwise, you get lost. Let's go to another juicy subject, and that's the piercings and the pains, the tattoos. What are piercings? Actually, they are fistula-like tracts. You can remove them. Sometimes it will have some consequences when you remove them. I will show you some of them, one of them. But tattoos are there to stay. They are permanent, and even if there are some treatment and lasers, etc., they're still being there. If we look in the medical literature, we only found about 150 articles about it, so we don't know a lot about it, but we see it in our practice. And there are not really baseline figures about all those things anyway. We, as urologists, need to deal with it like the dentists or the ear, nose, throat doctors do. They have nowadays some protocols for the treatments of consequence of piercings and tattoos, and certainly the urologists need to do it as well. It's not an act that people do just like that. It's take on average 6 months to take the decision to take a piercing, certainly genital piercing. It's take a few weeks to heal. When they do a genital piercing, they have at least 1 to 3 days of some bleedings. It takes sometimes a year till they get a real tract, real fistula. And they need to avoid unprotected intercourse, swimming pools, jacuzzis for a few weeks. So they need to do a lot of effort to have those things. And if we look at it, in each culture, there are some piercings and tattooing. In most of them, it was a rite of passage from adolescence into adulthood, but in the modern time, is more an identity or fashion issue and those things. It's really popularized in the modern world by the British Mr. Sebastian. Is a very famous one, and reports in the literature said a prevalence of 1 to 3% of the population with genital piercing, more often in men than in women. In England, there is only one cross-sectional survey of households with more than 10,000 participants of 16 years old and older, and body piercing was apparent by 10% of them, body piercing is more prevalent by women than by men, but genital piercing of 1.3%. It means that about 200,000 people have genital piercing in the UK. So each one of us as urologists will meet them in the clinical practice. Why they do it? That's not because of a rebellious act, and there are some beliefs about enhancement of sexual desire and sexual pleasure. There is no evidence concerning male genital piercing. Concerning female genital piercing, there is only one study who saw positive correlation between clitoral piercing and desire and arousal. What people say when they have it is that it helped them to express themselves. They feel unique and they feel being myself. That's quite an obvious reason to take it. When we talk about tattoos and hair removals, this is more common in young individuals, mostly sexually active, and it's really influenced by peers and media. That's different from piercing. What we know about characteristics of people with genital piercing, that there is significant risk-takers behavior, seeking new experiences. There is no evidence for high prevalence of sexual transmitted diseases, but when they do it in unprofessional way, there is some concern about the transmission of hepatitis B, C, or HIV. There is a lot of self-esteem issues, eating disorders, and certainly in the group of females with genital piercing, there are significant percentage of abuse in the past. Look at types and name. The most apparent one called Prince Albert, and it's named on the Queen Victoria husband, Prince Albert, that some people believe that he was wearing such a piercing. You have also the reverse one, and I show you some of the possibilities with the names. You don't need to remember, but some of the patients say, I have that and that. Then you know what they talk about. For the females, there are also a lot of variants. Sometimes they combine it also with tattoos, and it's Princess Christina. We don't know really where it's coming from. Some say from the Netherlands, some say from Scandinavia. This is one of the most apparent one, and the triangle and the labial and clitoral hoods are most apparent. In those cases, they don't have any damage normally to the urethra. They can damage the clitoris, but not the urethra. But you can imagine that in all those cases, they certainly damage the urethra, and we need sometimes to deal with it. The complication rate is quite high. For body piercing is 33%, and for genital piercing is 44%. The complication came because they didn't do it by a professional one, so the technique is poor. The aftercare was lousy. The body change after wearing long-term piercing, or partner damage, which also can happen. They don't come to us very often because they fear that we don't know nothing about it, or they fear that we are going immediately to say, take it out. And that's not what they want to do, because they did a lot of effort to have a genital piercing. The most apparent complications are bleeding, infection, fistula of structure, keloid or hypertrophic scarring, allergic reaction, urine flow interruptions, and even problem with the condoms. There are some anecdotes of trauma to the vagina and the urethra. I saw one of them in my practice. Choking on swallowed piercing, teeth chipping, trapping between the partner teeth, paraphymosis, priapism, and here is one of a guy who wanted to remove his Prince Albert, and the consequence was actually a fistule. And he needed to have a large repair of that fistule, like you do by hypospadia, for example. This is another nice thing. The guy came to complain that he lost his piercing during sexual act, and you see two parts of the piercing in the cervix. Oh, we needed to remove it. It could happen. The complication rate Probably you don't see it very well. There are 4 studies about male and female, and then you can see the percentage of complication is quite high. What do you expect for us? To help them to solve the complication and not remove the piercing. So what we need to do, in case of localized cellulitis, you don't need to remove the piercing because it's helping in the drainage. Given local antibiotics, advise on warm compresses, frequently cleaning, and it most of the time goes away. But if it will not resolve after 5 to 7 days, sometimes we need to do an incision and drainage, and in that case, they will need to remove the piercing. Radiographs are not a problem except if it's metal and they are going to the MRI, and be careful when you do some operation to use the electrocautery and to touch the piercing, because it will cause a wound, and a serious one. And remember, we need to know the specific difference, the risk factors, and how to deal with it, and how to consult those guys with genital piercing, because they want to wear it and to keep it. And our attitude is very important, because otherwise they go to get an advice from the internet or from local advisories people who give lousy advices and some health problem for these guys. Don't take them out immediately because they want to keep them in. And last but not least, I invite you to visit our website of the ESSM, where we have information about the European School of Sexual Medicine. It's an excellent initiative, excellent course started by John Dean, and we follow it with 10 days course on all aspects of sexual medicine. We have fellowship exams according to European Union of Medical Specialists, and I would like to invite you to come to the ESSM meeting in February 2016 in Madrid. Thank you very much.
Thank you, Kirby. So any burning questions? We're slightly running over time. Yes, Nigel.
You mentioned that sexuality was a fluid thing. Is it directly influenced when people undergo transgender surgery? And also, is there any evidence that the pattern of response of people changes with surgery?
Most trans people, certainly at the time of transition or around peri-transition, whilst they may consider sex might be important from the future, they're generally not terribly focused on sexual behaviour, because there is a mismatch between their body development and usually their image of what good sex should be for them. It's important that when counselling patients on hormone therapy and genital surgery, that they consider what their sexual options are, what their likely preference for sexual behaviour, sexual partners are going to be in the future, because making choices may limit their options for the future. I think that in general, I don't think that there is some fluidity of sexual identity, but I don't see it as a major issue amongst trans people. Most trans men who are birth assigned female sex, but have a male identity, want to have a heterosexual relationship, i.e., as a trans man will have a woman partner. And I observe the prevalence of same-sex relationships, homosexual relationships, to be about the same in the trans population as in the general population. I don't think that actually having surgery makes any difference to their sexual identity or their preference for sexual behaviours. But what they do need is proper counselling beforehand to make sure that they don't make choices which restrict their options for relationships and sexual pleasure in the future.
Thank you. PJ, number 2.
Yeah, I wanted to ask Professor Eisman a question. He touched on pornography in young men and how it causes sexual dysfunction. And in my clinics, I'm starting to see quite a lot of young men with this problem, but you didn't actually touch on the best management option for them. I wonder if you might be able to comment on that.
The best management, you mean for the group of looking at the sense as addictive, or with sexual problems. Two different things.
The ones with the addiction or the potential addiction.
In the group of that describe themselves as addicted, and if you see a really an social consequence for the daily life, you need to treat them, and you will need to have it in a multidisciplinary way, because it will need, in most of the cases, also a kind of psychotherapy. You will need to differentiate, is it a pure addiction because of some problem and avoiding reality in daily life, or is it because of compulsive or impulsive sexual disorder, which is a totally different approach. To say to a person, don't do it, will not help. Okay? So you will certainly need some kind of form of psychotherapy, otherwise it will not succeed. So as urologists, we cannot do it alone.
Thank you very much, everyone. I'd like to thank our colleagues from the ESSM for such a great session and for your participation. Thank you.
Thank you.